All right, all right. I think we're here. Can you hear me? I can hear you. It's great. Okay, look, we were hearing some little buzz yesterday, so I don't know about the buzz. We didn't hear echo, but we heard a little buzz. So I don't know if you hear that or not this morning. Yeah, she said it was me and my daughter was going round and round. She was like, "Mom, would you stop?" Because I was I had her on the line forever. I was like, "Look, I hear that buzz and it's irritating me." She was like, "It's not irritating me. It's okay. You can't get perfection." I was like, "Whatever." I needed to be right. So, good morning. How are you? Welcome, welcome. What's going on? How was your did you have your interview this week? Oh, okay. Yay! Yay! Congratulations. That's what's up. Cool. So you excited? You excited? Excited? Yay. For nothing at all? Oh, you ready. I know that's right. I know that's right. Oh. So how's your search going, Jesse? So everything worked out. Yes. Yes. I'm glad that everything. So how's it? So have you started yet? Okay, so you got even a little downtime right now to get that ebook together. How about that? How about that? Mm-hmm. That's what's up. That's what's up. And um, I went and did some additional research because I had someone actually contact me regarding this same thing, but they're not a nurse. And yeah, but the thing is, so I think on the nursing side, it'd probably be a little more permanent. He's a pharmacist, um, and they're allowing them temporarily to be able to set up independent labs during the same process, but it's only during the public health emergency. So I don't know. I don't know if they're lobbying or trying to do something to make this more permanent or not. I think if they do, then that would be great and lucrative. But I don't know. It seems a lot for something that's temporary. The things that they have to go through. Well, in his particular state, let me just say that it seemed a lot. Correct. Correct. But so as a if you were a nurse practitioner and you're working on your own, then those are things, because you would see patients regularly. So you would invest in that EMR system. I can understand that. You would invest in, you would already have your certification. You would already do that. On the pharmacy side, would you do that though? Because you don't see patients regularly. You don't have an EMR technically. I mean, that kind of system. And so that investment, I don't know. Right. So they'll be I mean, it'll benefit them for the long haul. Oh. Oh. Okay. Now, is it set up specifically for well, you would have to see the system. Is it a set up for seeing patients, or is it a specific specialty set up? As I know, they have kind of EMRs set up for like behavioral health and that kind of thing. Is it a specialty niche EMR or? Okay. Well, then that's a game changer there. Then that would work. That would work. So yeah, what states have you looked into? Because some states are, well, for his thing, they have some state specific stuff. Even though the public health pandemic, or the public health emergency, is kind of overstepping and temporarily not enforcing some of the state regs. They're taking their authority to the federal. Do they have any? Are they running into the issues state by state? Okay. Really, ma'am? Okay. Okay. That's what's up. So, are there a lot of nurse practitioners pursuing that route? Right. Right. So, are Do you see that there's lots of, I asked you that, the nurse practitioners that are kind of pursuing that route, or?
Oh, I think because one of the nurse practitioners that I have, done most with, she's friends with another nurse practitioner who is also doing the exact same thing. And she was talking about how she is already, she's already submitted her claims, she's already received payment. So I told her, I said, here's what you have to separate. Is she receiving payment or is she receiving the proper payment?
Amen.
And I told her that there's a difference because if she doesn't have, I said, because for instance, this particular nurse practitioner, she said before, like if people come in and they have symptoms, she does a sick visit as well as testing. So I told her, I said, okay, well, if you want to do a sick visit, that's fine. I said, but if you want to do testing on the same date on the same person, you have to append the modifier 25 to the E&F.
Oh, well, further rock that back a little bit, because adding that 25 modifier indicates that it's a separate, it's not related. You did a totally separate service in addition to, yeah, correct. Right. So that's no, not necessarily it's a separate, just, I mean, I know it's two different services, but using that modifier indicates that it is a separately identifiable service that's not necessarily related to the E&M. Otherwise, it's all bundled into one. So you got to be careful about the use of that 25, just adding that 25 modifier on there. Yeah, you could add that 25 modifier and get paid, but your documentation has to support why you're trying to unbundle that service. Right. But again, that's what I'm saying. But your documentation needs to support why you're adding that 25 modifier on there.
I told her that she has to put in there, because we put in, I helped her do a note and a template. And I told her that you have to put in there why the person is being seen, why you go to see, because you have to have some level of history, some level of exam, and some level of medical decision making. And your medical decision making could be rule out COVID-19. And then you administer whatever test you're going to administer to rule out COVID-19. So for that, you would have to have a modifier 25 because that's a separate act.
Correct. But again, you also have to have that separate note for the E&M service that you're providing. And that's what I'm saying. So your documentation needs to support that there are two separate services that are actually being, and why.
Right.
Yep.
And then, she said that what she does is sometimes she does two tests. She'll do like a rapid test, and then she'll do the PCR test that takes like 24 hours to get the results.
Okay.
So, depending on what the rapid test is, she said that she does two if people are symptomatic. So that's what I thought. I said, well, if you're doing two tests on the same day with the same person, and you're using different specimens, then one of them you have to have a modifier 59, so they know that you're not trying to get paid for, that you want to get paid for two separate tests, as opposed to you not getting paid or not getting maximum reimbursement because they are assuming that you're doing taking one sample and doing two tests.
Right.
Are they able to build the rapid and the
Yes. Yeah. So, and I was telling her, I said, so if your friend is not providing that level of detail, and if you're not, if the documentation is not supporting all that you do, is she really getting the max amount of money she should get? I said, so the thing is, you want to be paid for the work that you do.
Correct.
Yeah, as long as you're making sure you document that you did the work.
Correct. You're absolutely correct. Yeah, I saw where was it? I saw an article this week um that talked about, had any of you all ever attended like the coordination and maintenance committee meetings where they talk about the proposed ICD-10 codes that they're looking at? Remember, I think we talked about last week where they're going to start making the updates to ICD-10 twice a year instead of once a year. So they're going to do it in April um, and also in October. So they had a meeting in September, but the any opinions or comments on the proposals um, that's due in November. It's due on the Monday. I'm looking at my calendar like, wait a minute, it's due Monday. Um, which like, oh, it's here, it's here. Um, yeah, it's due Monday, and they talk about what did I do with the article? Um, some of the things that they're looking to, wait a minute, let me find the article. I don't want to misspeak at all. Okay. They're talking about, as far as the new codes or different codes that, or the proposals, some of them are apnea of newborns. They're looking at some type of neuropathies, hepatic encephalopathy, malignant pericardial effusions, procedures. They're looking at pressure control, intermittent coronary sinus occlusion. And so one thing that they do at these, and I think they're open to anybody. You can go with CMS does them. You can go in and uh I know, well, they were in DC. Um, and I know you had to get clearance and stuff to come in the building, but now I think they're online, so you don't have those same issues. But the people who are proposing for the different codes, they actually come in and kind of present their case, and so they're explaining, what they're doing, the rationale behind why they think XYZ code should be added. It's really interesting. I don't know if either of you have ever had an opportunity to kind of look at them. Yeah, it's really interesting. And it kind of gives you a heads up of what so when they do this information, they request opinions. From the opinions, they'll go back and determine, yay or nay, did they support their case or whatever, and then from there they would determine whether or not it should actually be a new code added. But like, you kind of get a jump on what's being proposed, why they're adding things, and sometimes it's a lot of stuff, and then sometimes it's just a few. But it's real interesting because it's normally from the medical um, side, so you get the medical professionals uh, reasons why, um, and why the code, why they feel it's necessary to have XYZ code, particularly if it's something that's already there that's kind of similar. They may be adding on or tweaking things, and so they try to justify what's happening. And so it's real interesting.
I think I saw it, and I was looking for it because I was like, I didn't figure out how to make an ICD-10 code because I'm tired of this right here. I know it's more people getting stuck in this stupid fish hook, and I don't understand why we got cat by alligators and other things, but we ain't got no fish hook. So, and I was trying to figure out. I mean, that went fishing, and you don't heard that they got stuff by their fish hook. There's not a code for it, and I'm confused at why there's not a code, but we got these codes for these other things from with a horse. I mean, a horn from an animal. Right. So, I was looking for that, and I found something about those meetings, and everything. So this is like you gotta sign in, and I think the first 1,000 people may get in to listen or something. on one of them and everything, and I was like, I gotta figure out how to get back to that one day. 3 days.
Hi, Dina. Welcome. Feel free to come up to the stage and introduce yourself. I also need to let you know that our room is recorded. So, but feel free to come on up. Yeah, so I think that's real interesting. Kind of how you get a jump on. So you can get, years ago, I would always wonder, well, how they know? Who are the people that know? Somebody knows something that knows something that knows something. and how do they know? And so this is an opportunity to kind of be ahead of that. So, and then when they're doing because so many final rules have been released within the last couple of weeks, this is how you kind of get a jump on, oh, okay. Or even with the proposed rule. So like once they decide, whatever, then they'll do that whole big proposed rule and then it'll end up in the final rule. So.
Yeah. I was reading about some of them this week, they were poured out. So Critical Care had some major changes they're trying to do. There's a lot of changes that are supposed to come out in 60 cheeks.
Yeah, I'm going to the CPT Symposium next week, so I'm excited about that.
I looked at it. I wanted to sign up for it, and I was like, no, you don't went to one conference this year. You broke it down.
Yeah, I've been live. It was several years ago, and that's when I realized Chicago wasn't for me because it was so cold. But because it's in November, and I was like, oh my God, the wind was just disrespectful. Is the only way I can put it. Just disrespectful. I felt like it was actually seeking me out. Yeah, I was not happy. Hey, Dina. So I'm going to that just to get a jump on, what those updates are. I got my CPT book, so I'm ready to go. I'm excited. CPT. I know y'all love ICD10. CPT is my thing. Yes, definitely. And I will be sharing. So definitely. 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 So it's yeah. In between my classes, I'm going.
The only thing I did this week was I did listen to some of the, I signed up to it. Tableau they had a conference this past week.
Okay.
So, on Wednesday. And Tableau is really, really big on, it's what they call a business intelligence software. So like, you take data and you can make it into all kind of like visualization.
Mm-hmm.
And because if you want to get into data analytics, like Tableau is like one of the key programs you will want to learn how to use, and they have a lot of free information.
Mm-hmm.
To use their platform, and kind of I've been kind of toying around with the idea of trying to branch into data analytics. So we'll see how, because with this CDI position, I will be able to, because it's a startup, so they don't really they don't have anything in place for real. So it would be easier for me to transition into data analytics with a company like this, because they're smaller, so you can kind of get in, make a name, like part of your niche. So as they grow, you could become the specialist.
So is the organization a CDI organization, or you're in a healthcare organization operating under CDI?
It's a healthcare organization.
Okay, that's what's up.
You need to and let me know about Tableau, because that's what I'm supposed to be doing some analytics with the new positions I get, and everything else. I take that one.
Well, let me tell you. Okay, so
here go the tea. I hear it coming. Here go the tea. I hear it coming. I've been waiting all morning. Here it comes.
Especially if you work anywhere that has like a .edu domain
Okay.
Well, you mentioned Tableau will give you all of their, like, they'll give you a product key, and you can use their entire software, including access to their training programs for free.
Wow.
And when I was a tutor at the college, I had a year, but I had a year free. It was nice, and I looked at it and I started it, but I was like, I don't want to get another credential, and I'm not using it. So it didn't. I didn't want to like invest the time. So now that now that I'm not even going to, because what I did was I copied as much stuff as I could. I downloaded as much stuff as I could while I had free access. So now I'm just starting to review that information. But if you don't have any kind of connection, like if you have a niece or a nephew in college, you can just have them set it up. They can create an email address. They can use a product key. You just use their login and stuff.
So it's based on the email. So it's based with the association with the organization, or is it just based on the email? I'm sorry, my phone ringing. Hold on. Okay. So is it based on your association with the organization, or is it based on just the email with the EDU?
It's based, well, what you have to do is you have to have a .edu. Then, like, the next thing you have to do is just scan an ID. Like, I just, scanned my work ID and had faculty on it. And I just sent that in, and they sent me a product.
Wow. Okay.
And if you're a student, you just have to send, like, student ID. That's really all you need. And they send you two product keys. And one is for their creative software, which is how you have access to their e-learning, and then the other one is for the Tableau product itself. You get the full product. It's not like student version is the real full product.
Does it update? So say you leave the organization, but you still have. Will they provide updates for it, or it is what it is? It's what you got. So you have access for a year, and you have to do it every year, or okay. Interesting.
Okay, I think I found it. It's just like, okay, it's like table with AU at the end of it.
Yeah.
Okay. I'm digging the size and stuff.
And the great thing about that, I'm glad you brought that up, Jesse, because when we talked about the future of HIM, one of the when we were at the House of Delegates meeting and we talked about that, one of the skills that we really kind of was trying to drill in for health information professionals is data analytics. And so regardless, even if you don't get into the CDI space, you still need to have some sort of data analytics behind you to be, kind of to stand out in your position. So this is this is good. This is good. I know a couple of years ago, and I wasn't able to attend due to travel, but a couple of years ago, our state association actually had someone come in and do a Tableau kind of walkthrough. They did a whole like orientation to it. And so they were kind of, I love my state organization because they are so forward thinking. Shout out to Ohio. But they have, they had somebody kind of walk through and talk through about data analytics. They were kind of on the forefront of that back then, even though data analytics has been around forever, and a lot of people didn't really take advantage of it. I'm sure they wish they had now. in hindsight.
Let me tell you, you can make some money. Sarah, if you have any opportunity to utilize Tableau and you have any opportunity to learn it because you can write your own paycheck. I toyed around with the idea of learning that. I started 2 years ago looking into data analytics.
Mm-hmm.
It was because I told through for I was at this job and this lady was doing their data analytics, but I had no clue about the code.
Mm-hmm.
If you know code, if you know ICD10 CM code, and you know Tableau, you can make a fortune.
Oh, wow.
My agent, my recruiter who got me, because I got an audit position at a local insurance company. I was telling him that I was learning Tableau and SQL. He told me in 2019 that if I learned Tableau, he could get me a contract position paying between $60 and $75. That was 2019.
Wow.
I'm gonna look into this stuff, Tableau. I'm looking at it now. Okay.
And if you have to pay for it, the creator license is $120 for a year. Then if you want to use the full Tableau production, the full software, you can pay I think $70.
Yeah, I'm looking at it.
It's only $120 a year, or is a month?
No. The creator, to get access to the training is $120 a year.
Yeah, and then this one right here is $70 a month.
Right, that's for the full production software.
Okay.
Because they give you a free version, they have a public version that you use the free, but the public version is not the full version.
Yeah, so they have a free trial.
So is the public version the one that you get the license for with the EDU?
No. The EDU gives you the full production software.
Oh, okay. Okay.
The public version is just, you only get like, the public version is not, you don't have the full extent of the software. You can do some basic things, but now when you sign up for your free, when you sign up for a 14-day trial, you get the full production for 14 days.
Okay.
After that, if you don't have a license, then you get bumped down to the public.
Okay. I see a training in my future. Because y'all know, wait a minute, y'all know I'm a student. I see a free training in my future.
They have just come out with a certified healthcare data analyst, and the certified data analyst and things. Yes.
Through Tableau?
Through Tableau, yes, ma'am.
For healthcare.
No. It's the certified data analyst, but you can use the application in any platform.
Okay.
Because
interesting.
They have a CHCA credential.
Correct.
And that's a certified healthcare data analyst, but that I don't.
Are they still holding on to that?
I don't know why, because first of all, I don't even know. If you know how I feel about it. Their first time pass rate for their credential is 10%. That's ridiculous.
So I know. I'm sorry. Go ahead. I didn't mean to cut you off. Go ahead. Oh, I know a couple years ago, this was what's her name? Diane Smith, when she was president. They were considering walking back some of these credentials because they felt like you already had organizations that had credentials in some of these areas. And I thought data analytics was one of them. And so they were contemplating kind of refocusing where they're, being more strategic about where they're going to allow or have credentials. So they were, maintaining like their coding credential, maintaining the RHIA, RHIT, but rethinking some of the other ones. And I thought it was either that one or informatics. Something was going on with either the data analytics or informatics. I vaguely remember that. I don't know where they landed.
Well, if you get any kind of, because I want to get the desktop associate first. That's a Tableau credential. That's like the basic entry level one. I want to get that one first, and then I want to play around with it. Then I want to get sometime next year, like maybe like the second quarter. I do want to that would just be amazing on a resume for a coder.
Oh, definitely. Like I said, because we were talking about, we felt like for any HIM professional or HI professional, that's where they're changing kind of the moniker. For any HI professional, that data analysis piece is going to be golden.
Because you still need someone to bridge the gap, because they don't know, data analysts don't know the ICD10 code COPD. So they have to have some kind of interaction with someone who knows code, because that's the information that they will draw their information from to even compile the report.
Right.
And if you have both skill sets, I mean, you will be a unicorn.
Right. True. And that, I think some of that is true even in the IT space too. As they build some of these, like the EMR platforms and programs and the different, because even they're looking at various apps and all kinds of things, but you as a coder know how things are interconnected and what should be what, and the guidelines behind it, and the method to the madness, if you will. So you may not have the IT part, but you got the other part. And if you're interested in that area of health information, I think that's another thing that you can kind of delve into, is kind of IT and learn the IT piece. And that's how folks are unicorns out there in that space, especially with these EMRs. I mean, you have the major big ones, it's the monopolies, but there's several still smaller ones that are out there that are coming into the space.
For instance, like everybody knows Epic is huge, but Epic has training, Epic has certification for their different levels of EMR. And from what I understand, like they do, but now from what I understand, it's kind of hard to get into the training because you just can't say, "Oh, I want to go inside the training." Epic has rules and regulations for who they accept, and you have to be sponsored and all this other stuff.
Right, because shouldn't you be with an organization that's actually using their product? I mean, you can't just be like off the street.
Right. But also, but then there's some money involved, so who's going to pay for it?
Right. Because I think you actually go, well, I don't know what it looks like. Yeah, you used to actually go there. I was just thinking, I don't know what that looks like in the pandemic, but yeah, you used to actually physically have to go to their headquarters.
And that's why I'm thinking, because then you get into, but that's definitely a viable option, and they do pay well because Epic is nationwide, and those training positions and application positions are highly sought after. And one of the things I'm going to do this weekend is I'm going to do another video for my Coder Nurse channel, and I'm going to talk about nursing informatics, because a lot of nurses they just love going and spending their money on nursing informatics. And anybody that I know that is trying to go into nursing informatics, I try to tell them to save their money, because it sounds nice, but it means absolutely nothing. Because what nurses have to get past, and I did a video about that the other day, last week, and I said nurses are kind of like insulated, you're in your own bubble, and you think that you make all this money, when in fact, in actuality, there are a lot of people out there who make a whole lot more money than nurses, and they're not exposed to all kinds of nasty diseases to do with it. And the average registered nurse in this country makes about $70,000 a year. That's really not a whole lot of money.
Right.
In the grand scheme of things.
Right.
So, of course, on the coast, you can make a little more, and you can work overtime, do all kinds of things to supplement. So you can increase that, you can make $90,000, if you want to do overtime and all other kind of stuff. Or you can learn a skill to make $90,000 Monday through Friday.
Bring it home. Bring it home. He always, yes.
And one of the things that that I want to impress upon nurses is especially when you want to talk about IT. Like, I don't knock any education. If you have a bachelor's degree, I think that in healthcare, I think that's more than enough. Now, if you could build on to it, especially if you want to talk about tech. If you want to talk about tech, you have to get certified.
Yep.
Tech is not about degrees.
Correct.
Because tech is very focused and very specific.
Correct.
And that's where these people get necked up with these nursing and informatics degrees, because it sounds nice, but you have not mastered anything. So you have to go somewhere, and somebody has to train you. You still have to pick a niche, and somebody has to train you in that niche, because you haven't learned that. You just learned these broad concepts, but it's not specific enough to get you a job. And the three areas that you can go into with a nursing informatics focus is IT security, applications, and data analytics. So if those are the three options, why could you just save your money and go directly into one of those options?
Mm. That's good information. Yes. I feel like I need to have a buzzer or some noise makers or something. Yay. Yay. All right. Yay.
I have managed to make it work for me. And I have done very well with it, and I have it. But you just gotta be specialized. You gotta know how to move around. You gotta know, and yes, when I accepted my offer, yes, I did counter. I always asked for more money, and they gave it to me.
Look, that's a class you need. You need a whole training in that's a training in and of itself. How to negotiate your salary. 101.
Well, I didn't know. Really, I was surprised that they called me back. You know, you said they say apply, you never know. And I applied and you don't know.
I always tell people apply. Just,
And I do. I did. I applied and and it don't hurt me if they don't call. But when they do call, I was like, oh my God. So he told me that, the other day, he was like, you know about yourself. You should bring that price up. So guess what? Everything that I've been through on the interview or somewhere, I went to my local family and I do exactly what I've been told to do.
Yes.
You gotta get your life, because it's out there. And the thing is, there's no such thing as one of the best pieces of advice I ever heard when it comes to negotiating is there's no such thing as they don't have the money. When someone does not want to give you more money, it's because they don't see your value.
Mm.
It's not because they can't afford it. Companies have money. It's because they don't want to pay you that amount.
All right.
And if that's how you feel, have at it. Go somewhere else, somebody else will give you what you want. Like it took me, I was looking for CDI jobs for 2 years. It took me 2 years because first of all, I was not going to do it for $100. And I just wasn't. And even with this one, like I really, I'm like, no, this is the bracket I want to be in. And especially, and how I told it is like, you want me to create a program for you. You have nothing. That costs.
Yeah, you started from the bottom. That costs.
That's true.
Because here's what else. If you ever, I will tell anybody, and I hope this needs to be recorded.
It's recorded.
I made this mistake one time without ever doing it. you interview for a CDI job, especially with a startup or someplace that they don't really have a CDI person and they want to create a program, never ever when they ask you, if you were to get this position, what would you do first, or how would you? Don't tell them anything. Don't lay out how you would implement anything, because at that point, that's a complication.
Right, you giving free advice.
Exactly. And if you give them anything, they don't have to hire you. They can find somebody else that they really, really want, and then give them your ideas. No. So don't say anything. And this is what happened. So what happened was, on Monday, I got contacted by my supervisor, by my new supervisor, and she wanted to set up a time to meet on Thursday, this past Thursday, to talk about, my plans for the role. So I had a contact. So I called my contact. I'm like, yo, what's going on? So that sounded like another interview. I thought I was done. So I told my contact, I said, listen, I'm not doing that. I am not talking until I get off. I got my offer later on that day.
Wow.
You gotta know how to play, but these people don't care. They will suck you dry and give you nothing.
So is it a remote position that you got?
Yes.
Okay.
Yes.
Well, good for you.
They're in Tennessee. Their headquarters is in Tennessee.
Okay. That's what's up.
So I'm trying to get this into data. I'm trying to move this data analytics. So I'm telling you, by the end of 2022, the coding nurse is going to have a 6-figure salary.
All right. You heard it here first. The coding nurse will have a That sounds like a very smart goal.
I'm inching closer. I'm closer now than I was last week.
And it's doable. A 6-figure salary is very doable. Very doable. That's what's up. Wow. Well, we dropped a lot of little gems today, especially this Tableau thing.
Tableau is everything.
That'll be something
They
new.
make it so accessible. And people sleep on it. I can't say people sleep on it. People don't know about it.
People don't know. You're absolutely correct. If you're not in that space and you're not, but like you said, this isn't necessarily for healthcare. If you're analyzing data for anything, anything, here's a tool. Here's a tool. That's what's up. Hey, lady, how are you? We're doing good. How are you doing this morning? Is it morning where you are? Okay. So I'll let the coding nurse give his update again.
Tableau is a software program that is under the heading of business intelligence tools. And they have a few. They have Tableau. They have Power BI. Power BI is I believe by Microsoft, and they have Cognos Analytics by IBM. But Tableau is the most popular. It is a business intelligence tool, so it is a software program where you import Excel spreadsheets, or you can even import PDF, any kind of data, you can import it into their software, and you can manipulate it, and you can make visual presentations based off of whatever it is you want to show. You want to show growth. You want to see where your business, or where keep it in health. Like if you could say you want to know, or let's say like an insurance company, what is their most prevalent diagnosis? Tableau can help you research the information, come up with a program, and you can formulate. You can show them a list. You can color code. You can do all kinds of things with Tableau to manipulate it and make it visually appealing. And all you do is you relate data and you put it into a visual concept. That's really all it is. And you just have to know how to use the program to make a visualization to reflect the data that you want to show. So if you wanted to, if a company wanted to know what are their top 5 ICD10 diagnoses, you use Tableau to find that out, and you put it in a presentation. If you wanted to see, if you had healthcare information, you could determine what is the most common diagnosis in the state of Virginia or in Massachusetts, anywhere. You can figure that out with Tableau, and you would just need the underlying information or the underlying data set that would have that information.
Right. So, how does medical coder use that? And do you use it?
Well, a medical coder doesn't use it, but if you're a medical coder and you want to move into data analytics, that's when you would use it.
Yeah.
You know what we need to do, y'all?
What?
We need to make a spreadsheet of all the areas that I told you to work on. Because every week we have a new area that we discuss.
Yeah. That's what I said. They get the tea here.
Data analytics to, from, you got so many areas from, compliance to investigation to law to, there needs to be, some data of all the areas of coding if you can fall into.
But I think it's really about, your passion and what it is that you're interested in doing. So you can take that and level it up to.
Yeah, but, you never know where you can, you may have a passion, but some coders don't even know that there's so many other areas of coding that even exist in the world. So, until one day, you just fall upon something, you're like, oh, really?
That is true. But what I have found is I don't know, I think that it's one of those, there's a Chinese proverb, I think they say it's Chinese, a Chinese proverb that says, when the student is ready, the teacher will appear.
Mm.
So I think that people have to be ready.
Mm-hmm.
And you can give some information, and it's just, all you're doing is wasting your breath, and that's to relate it to people talk about, that's why you don't cast your pearls before swine. Because if they're not ready, they're not going to receive it, and you're just going to waste your time.
Exactly.
And I know, that's why I came up with the Coder Nurse. That's why I started charging people. Because I'm like, I got tired of telling people stuff for free, and this is for real. They don't want to listen, and then they're going to come back after the fact. So that's really how I feel. I started the Coder Nurse out of frustration. I'm like, well, if I'm going to talk, I'm not going to get paid.
I never thought about that. Well, I always just feel like I'm just doing my good deed.
Listen, I do a good deed too, but it comes with a PayPal and Cash App.
Oh my God.
Because what I did today was a goodwill offer.
That was a goodwill offer. You are absolutely correct. And that's how you do it. So you start, you provide some useful, tangible information. And then from there, if they need to know or want to know more.
Then you go from there.
Cha-ching.
Your girl over here gives you every information. Why?
Right. Right.
Clarice, I think you and I are very similar. When I say I'm a digger, I will research. I just need just give me a keyword, and I'm off the race.
On it. Do you hear me? And then, well, and again, from my perspective, like you wanted to make sure that, because you have a passion for the nursing side of the house, and particularly for nursing entrepreneurs, and making sure that they get what they need. So when they're submitting their claims and they're getting paid, that everything is done right. And I think we share that as well, because I'm all about making sure folks would be like, oh my God, I got paid. I got this. And I'm like, but could you keep it? Did you, you did all of this. Somebody told you, but did they understand how they were supposed to do it and why they're supposed to do it that way? And putting all those pieces together. And then that way you can rest assured that the claim that was paid is your claim, your paid claim. And you don't have to worry about that. And then even in an audit situation, my documentation is good. The medical necessity is here. I've done what I need to do. I've crossed all T's and dotted all I's, and you stand firm on that. Otherwise, you scrambling, you nervous, you done lost money going out the door. I mean, it's a mess. It's a mess. So yeah, I'm excited. That whole Tableau, that's a game changer, and that's something that possibly you can kind of tell people, particularly if they are interested in that space, because as we've said over and over again, things are changing. Healthcare is changing. Healthcare is shifting.
And the good thing is, see, there was a time when you had to learn SQL, which is a database language.
Yep.
SQL is SQL. It's just
Yep.
structured query language.
Yep.
And you can still learn it, but basically these business intelligence tools have made it so that you don't even need to know SQL. All you really need is an Excel spreadsheet or some other kind of document that houses the data that you need. Then you can extract what you need from it.
Yep.
You don't even really need it. You can do some of the things. You can manipulate the data once you have it.
Yep.
You don't have to use SQL to do it. Now, if you would need to learn SQL, I mean, it's not. SQL only has like a few commands. It's not like it's. I started learning SQL when I was in IT, like when I was getting all these IT fixes back in 2000. So it's not at all. None of this is really extremely difficult. It's just you need to know how to manipulate what it to get it to do what you need it to do. That's it.
That's what's up. Well, I'm excited. We had a lot of good information. We learned how to be in the forefront of these ICD10 codes, so you can be in the know. We got that. We got the whole data analytics thing with Tableau. I love that. We're with bated breath waiting on the ebook. Tara gonna take care of the spreadsheet of educating folks on all the different areas and venues that they can go into as a coder. We all got walking papers. We all have assignments. And the collaboration. So you were on in that room last night about the collaboration and how they were running into problems. And I was just like, wow. Did you hear that part of the room? Yeah. That's unfortunate, huh? It's not coding, it's a nurse room. But they but it translates. it translates. Just folks not willing to share information amongst each other. And to your point, Jesse, that is a slippery slope, because you could give and give and give and not necessarily get in return, and then you feel some kind of way. But yeah.
Oh, definitely. I mean, it was just all of that was like deja vu in some way, shape, or form. I've been there, or I've seen it done. So, and this is exactly why there's a nursing shortage. Like, people don't really like it's rough being a nurse day to day. People don't even realize it. It's not even about the work.
It's not. I hate to see the what have I experienced the hierarchy, and how you're immediately asked about your credential or your level or your and then from there it oh, you don't need to know this, or that's not for you, or I've seen that in play, and it's like, wow.
done to be like maybe early on in my career, and I guess because I'm a man, I don't really get the mean girl stuff that women do to other women in healthcare. But me being an LPN, like RN, there are some RNs who think the LPNs are nothing but glorified CNAs. Like we don't know how to do anything clinically, we don't know how to calculate drugs, none of that. They don't even see it. And you have to like that was one of like that's why I never wanted to go back and become an RN. I'm like I couldn't go back to school to be more bogged down in this nonsense. No ma'am. So when COVID came about, because I had left nursing altogether, I was an idiot. I was I wanted nothing to do with it. And when COVID came along and I came back into it, I'm like, okay, well now and then I finally saw where I could do this and become an entrepreneur. This is something I can really see myself doing.
Right.
And what is so interesting is that I'm an LPN, and most of the nurses who have taken my classes, I've only had one LPN and I've had 3 nurse practitioners. So the bulk of the people who are taking my classes are RNs. Like they hit me up all the time with asking questions. Well, how can I want to leave? How can I do this? And they don't even really know what kind of skill set they have. Like I try to tell anybody, like I have a woman that I'm training now. Like if you work in ICU for 10 years, you need to go into clinical documentation. You need to go into audit. Or like if you like I had a woman who she worked in the OR. You need to go into surgical audit. Mm-hmm. That's an easy that's like an easy transition.
Very. Very.
Because you go into the field that you know, at least to start into that part, you know, it helps.
Yep.
And they think that you have to, and it all is just bogged down into how you think as a nurse. They think that you have to go to school forever and ever to transition. And I'm like, no, you don't. Like, you as a nurse already have anatomy and physiology. You already have pathophysiology, pharmacology. You already have medical terminology. You already know all that stuff. All you really need is you need to learn the code set and you need to learn reimbursement methodology.
Yep.
You need to know what PRG is, how it works. You need to know what an HCC is, how it works. You need to know what gets paid out of what part of Medicaid.
Yep.
That's what you need to learn as a nurse. And after that, you're off to the races. And that's really how I designed it. And the reason why, I'm like, it's a hop, skip, and a jump, but they don't realize.
Yeah. Yeah, and their opportunity. And I see, you know, we probably be fighting nurses again.
But not necessarily. When it comes to HIM, like what HI is, you educated us today. When it comes to HI, like listen, Clary, there's nothing that a nurse who comes into coding can do better than you. Nothing.
Yeah, everybody has their own niche. I totally understand that. You're absolutely correct.
You just have, because I'm telling you, there are positions, I've seen positions that say are have nothing to do with clinical care. It's coding, RN required, and I'm an LPN, but I don't qualify.
Mm.
That's what I was telling you. My friend girl works for Blue Cross, and she's like, yeah, she told me, I don't know what I'm doing with these fellas, but you're a nurse, so that's how you got the job. She's like, you know about this part. I don't know about this part. I just know about what's in the record or whatever. I don't know how to read a record. Everybody. So you don't know what button you over there pushing. Why are you pushing?
They don't.
It ain't. She don't know 1 + 1 = 2. She just knows how to get to the middle. No one.
Wow.
But you know that if I push this right here, it's gonna give it a 2.
One of my best friends, she got her BSN back in the day. One of her classmates had, when she found out, that's my friend, I mentioned to her that I was doing coding. And she reached out to me. She was doing home health. She was in an office submitting claims to Medicare. And she was like, so I said, well, when you do your coding, I said, you have to pick a primary diagnosis based off of the discharge summary and based off the coding guidelines. Because sometimes what the person is being seen for, you might not have that as a primary diagnosis.
Right.
Based on the guidelines. So she was like, really?
She
She said, I just pick what I think is the worst and I later on, she said, then she told me that they were fighting denials because they had to pay back $10,000. Exactly.
I wonder why. I wonder why.
But get this, there are home care code positions, just coding positions that I cannot give because I'm not a registered nurse. I'm an LPN, but I'm not a registered nurse.
And that makes absolutely no sense to me. And they're not requiring any certification or anything from them. They just want them to be a nurse.
They call themselves training them. And then if you were to go and get a credential, if you were to go and get certified as a home care coder and then go get certified in Oasis, she could make a fortune.
Oh my goodness. And then you wonder why the audit environment for home care is the way it is. that practice right there is ensuring auditors for years.
And especially now that home care started in 2020, they switched over to like PGM instead of fee for service.
Right.
Oh, it's gotten very real.
Right.
But that's what goes on, and I just find it. I find it funny because I'm like, at least learn. Like I think I shared with y'all a couple weeks ago. This nurse contacted me. She didn't say she was interviewing for a CDI job. She got a CDI job in her hospital. She came from the ICU and didn't know she wanted to learn coding as quickly as possible. But she had a CDI job. So you have to learn, not only do you have to learn ICD10 PM, but you really got to learn reimbursement methodology. You really got to learn what an MCC is versus a CC.
Right.
You really got to get on your sequence, and you really got to know sepsis. And you really got to know POA status. Like, that's what you got to know. And I'm like, they just handed her a 6-figure career.
Wow.
And she don't know jack.
But because she has an RN behind her name. That's amazing. That's amazing.
I can show you some jobs right now. And
that's amazing.
it is.
And then what makes them think that, oh, it's so much easier just to train you in the coding part of it? Because nursing, your brain thinks a little different. So what makes you think, oh, well, you can just easily adapt this. This would be easy as long as you got this part.
And the reason why, what I've learned through the coding nurse is because I talked to another woman who has a coding training company, and she shared with me that she said I don't like to work with nurses. And I told her, I said, I get it. I said, how nurses think, I get it. And I know the language, I know the arrogance, I know all that, so I don't have a problem with none of my students, because I know how to shut you down in 2 seconds. All I got, because it's not about that. And what I have all of them. Because what happens is they skim. They don't pay attention to detail.
Right.
And I keep telling, and that's what they have to, all of them have to learn. And they have to stop skimming, and they have to stop thinking. There's no medical decision making in coding. You code what is there.
You code what is there. Yeah.
And so I get that, and over time, over a couple of weeks, I see how they begin to slow down. I see how they begin to just code what is there, and they start to make associations. And I started telling them, I'm like, see, everybody, I know you all think that, and like week one, I was just going to code in the book, and that's it. I said, you'll see. And when I tell you, when I give them a quizzes, and we go over it, and they box them up, I'm like, I could see why. I said, I see that these are causal relationships, and I give them documents detailing the causal relationship, what they're supposed to do. And I told them, I said, you're never not supposed to know in coding because you have a guideline for everything you can access.
Right.
Until you memorize it.
Right. Wow. That's like teaching physicians. I had the same thing when teaching physicians coding, particularly residents. I worked with a university program, and they come out of school, and everybody's always like, I wish we would have known this when we were in school, and no one has actually officially kind of put that into the curriculum. But the healthcare organization that I work for was tied to a medical school. And so they had to had all the residents come through that. And so we were trying to teach them about the reimbursement. And this was, here I am dating myself again. This was prior to a lot of the providers or a lot of the physicians being hired by these organizations. Is when you would, just go out and open your own practice, and getting them to understand that. So it's similar to what you're doing with nurse practitioners now, and just getting them to understand it's not about your medical judgment. It's not about, the diagnosis. I mean, at some point, yes, it is for you as the documenter, but the coding piece of it, or understanding that it's not about that. We're just taking what it is that you've documented and providing the information for that. And if we see that there are things that are not specified, or there's some ambiguities to them, then that's when we would go back and say, you know what, hey, I see this, and I see this, and I see this. Do you see the same thing I'm seeing?
One of the questions that I asked when I met with my new manager, because they don't have, because what people don't understand is, like, to be effective in coding and to have a successful reimbursement program at your facility, you have to have clearly defined rules.
Yes.
And you have to have, because I asked her, I said, well, do you have any, because the main focus for this particular healthcare company is renal care, like chronic kidney disease.
Okay.
So I asked her, I said, well, do you have protocols? Like, what do you have, like, what are the protocols for being, for querying a provider for anemia and chronic kidney disease? They don't have it.
Wow.
So, but those are things that, as a coder, you should have. And when you get into the CDI, those are the things that you need to have, because that's something that can boost someone's risk adjustment factor.
Correct. And the revenue. Correct. And the revenue. You're absolutely correct. Yep.
But you do it by having guidelines, by having protocols. Like, what are the clinical indicators for us to query for anemia and chronic kidney disease? Or what are going to be your clearly defined, EGFRs for, the suspect, to query the provider for an increase in someone's stage of CKD?
Right.
Those are things you should have. And everybody should be on the same page.
On the same page. And then at some point, once you've identified and done, once you've identified, you've had the discussions, then trained them, that shouldn't come up anymore. Everybody should be on the same page.
Exactly.
And you move on to the next issue or the next problem.
But you know what their problem was? Or is? It's not even coding. Their problem is billing. Because they have, because they own this. I just had a question I wanted to ask. So she was telling me that what they do is they have is enrolled in some kind of HMO, and they don't have a referral from their provider to see these people.
Wow.
Why is that even happening?
Say that one more time. Say the end.
I said, why is that even happening?
No.
And that could all be worked out.
So they're not getting paid because, no, say what I missed the piece.
Oh, so they are subcontractors. Let's just say a subcontractor for humanity.
Mm-hmm.
So they go and they see this person. They do a telehealth visit with this person.
Okay.
They go to this clinic, and the claim is denied because this person on the Humana side has an HMO and they need a referral from the PCP to see the person to see the practitioner that is billing this telehealth for chronic kidney disease management.
So why wasn't that taken care of in the front end?
Thank you. Thank you.
That's a whole registration piece.
Thank you.
That's a whole registration piece. And so when you get all that information there, then you know, because you bring it back nightmares. I worked with an organization and they were providing all kinds of services and nobody was validating and checking anybody's insurance. I was like, y'all just throwing money out the window. Y'all, I appreciate that you are passionate about educating and helping and providing therapy for this community, but y'all doing it for free. And if that's what your business model is, then y'all doing a great job.
Now, what she said, this is the question I wanted to ask. She said that they currently are using the modifier 95 for telehealth and, on their E&M code. So she also told me that that apparently started like at the end of the year, something is going to change where with the location. So she was saying that their legal department told them that the providers are going to have to start using their personal addresses for a location in that state for them to bill. And I'm like, because they see people in different states, and they have providers in Mississippi, Louisiana, and other places.
Mm-hmm.
And I'm like, so she asked me, I said, well, I've never had that. I said, I've never had that experience. I said, I don't know anything about that. I said, but it just doesn't sound right to me.
So this is, I just did a video. I just dropped my video on this yesterday. So the place of service codes for telehealth, one has been revised and one is new. The revised one deals directly with providing telehealth services to the patient that is not at their personal address. So say they're sitting somewhere else, or they're going to a place and the provider is not there and they're providing that telehealth service. The other one is actually having the telehealth service in the patient's residence. So they're splitting those place of service codes. And so that's where you would definitely have to make sure that you're documenting, or even on the claim where you're putting that address, because you're providing that service in that, or that patient is receiving that telehealth service in their own home.
Yeah, see, that's what I thought, because I thought that the place of service went to where the person was receiving the care. So he was saying something about for telehealth, where the provider is, your location is, where the provider is giving the care, whether it's, and I'm like, see, I have not dealt with it. That's not. So they have a billing person at their hiring, but I just want to know just for my own, information.
Yeah, it's a little different. And you got to couple that with a lot of this stuff is real loose and requirements are relaxed because of the public health emergency. So things wouldn't necessarily it was really, really strict on where the patient sat and where the provider sat. A lot of that has been relaxed. And they're trying to keep it that way because they feel like this has been, especially in, I'll say in mental health and in any rural areas, this has been a game changer, allowing patients to actually receive services that probably wouldn't have necessarily received services because of transportation issues or access or what have you. And so they're trying to keep those things in play. But those telehealth rules were really, before this pandemic, were real strict. And so people were like kind of staying away from it. They wouldn't do it because you couldn't just use an iPad or a phone or whatever to have the telehealth service. You actually had to have some for real setup. And so patients were actually going, so while they wouldn't necessarily go to the provider's office, they would go to a place that was set up for them that had that equipment. And so that would be the place of service versus sitting in their home on their iPad or their computer having that service, which is now how they are able to do that. Does that make sense?
It does. But they still need some kind of definitive explanation about why would they use their personal address as opposed to a business address. Because I'm like, well, I just want to know for me, I'm asking you some more research. Because, and I'm like, well, and here's the thing. They have a legal team. I'm like, how come the legal team doesn't know? Like, you don't have people who, you don't have healthcare attorneys. Like, what kind of attorneys?
So they're providing the telehealth service at home, the provider. And so they're asking them to put their private address?
Yes. And then one of the other workarounds was they were saying that the company could set up basically set up addresses, set up locations just for billing purposes. But I'm like, now that sounds fraudulent.
That sounds fraudulent. And why wouldn't you just do it under the organization? Right. If you were taught, but then they're not, that's messy. Because then they're not necessarily part of they're contracted. That's messy. So the contract, so the subcontractors, are they all under one umbrella? So there should be one umbrella so that those subcontractors fall under, and that umbrella should be the one where they would be billing that service through, with using that address. Right. Or are these practitioners individually billing? That's going to be the question. So if they're individually billing, I understand that. But if they're billing their services through the contractor, then that contractor is the entity in which should show up on that claim form.
Right. Because the money should be going. Well, I think that's how they do it because the money goes to the company, not to the provider. Right.
But I mean, you still have to put the provider's NPI and you have to do all of that. However, the address, if the money is going to the company, the address should be the company, period. That's interesting.
It is.
We learn something new every week.
I'll have to keep you posted.
Yes.
This is what makes, the HI industry just so interesting because it's constant change.
Constant. And the pandemic didn't help it. No. It didn't help it at all. It made things even more convoluted and confusing.
But in some ways, I mean, it was, well, the main winner of this whole pandemic was people wanted to work from home. True.
Because I couldn't understand why they would not allow certain tasks to operate that way if people wanted it. I understand if you didn't want it, And so those who didn't want it, they're probably feeling some kind of way and feeling forced. But those who did, I didn't understand why. Well, I take that back. I understood why. The micromanagement of the managers. We've already had that conversation, so I did understand why. Because if your production, your work speaks for itself, and there's always ways around doing it. I mean, look at CEOs of corporations. They're not always sitting in whatever. They're on the move, but they're working. So yeah. Yeah.
So that's what I went to that little scenario, and I'm sure once I start, I'll have more information to share because I'll get a forum.
Okay. Okay. Well, that's good. That's good. All right. Well, we are at the 10:30 Eastern Standard Time hour, and I know you like to stick and move. This is your day to do that. And I appreciate you. I so appreciate you coming on and being part of the team. Look, I feel like we're a team now, being part of the team, providing information, dropping the T. I try to give my compliance and coding piece, and you got the other CDI and nursing and entrepreneurial. I guess we both share that, and just all the things that we try to give folks on the Saturday morning tea. So I appreciate you. I'm still trying to get you to come on in the room. I don't know how I'm gonna get you to do that. That would be the game changer, sir. But yeah.
You know what? I'm gonna have to. I would just have to do it for my computer because and it's sitting right next to me. It's right.
Sir. Or we just, we gonna have to. We'll get together and we can do a walkthrough and we see how you feel through that. You know how I do that, my little walkthrough. So we can definitely do that and see how you feel, how comfortable you are in that. And that way we can do that.
I do PowerPoints every week, so I'm comfortable.
Okay. Well, then you had just come on in and, we can share some things. And again, we can connect everybody, tie everybody with all of the platforms and programs. You know me, I dug until I got it together. Now, the only thing I can't do, I think Clubhouse has restricted some things. So you can't, I can't show the screen anymore. And I can't do something else. It wasn't allowing me to do. Oh, it was the showing the screen. So every time I tried to show the screen, the sound would go out. So they've done something on the back end. But I'm still able to broadcast the actual room, the audio of the room. You can't do anything visual of the room, and I guess that's fine. Yeah. So cool. Sir, I'm going on that website today. Today. That's what I said. All I got to do is make sure. Now the problem is, well, not a problem. I just have to have it mailed to me. It's getting the school ID because I go to school in DC. My school.
So, but you're currently registered, right?
Yeah, I'm taking classes as we speak, sir. I got homework today.
So what you can do is because they'll tell you when you go on, when you sign up for the student.
Or just send a copy of my transcript or something. Or registration.
Yeah.
Okay.
And I'm telling you, in like a day or two, you'll get an email that says product, and you'll get 2 product keys, and they'll be mailed separately.
That's what's up.
One will be for the full production, and one will be for the creator, where you're able to look at all of the training.
And we can add that to our little our toolkit of educational offerings that we will provide. We could tag team. I see a collaboration in our future.
Because believe me, Clary, I'm big on exposing gatekeepers.
Mm-hmm.
And you and I both know that it's the people in HI who knew about Tableau, knew it's free, knew all that, but I'm telling only us like you.
Oh well, nobody. And that you're absolutely correct. That is a game changer, a huge game changer.
I mean, you can actually access these resources for free, and actually the study material, the program for each certification you can get for free. And they give it. I mean, they give you sample workbooks that give you sample spreadsheets to use to use to do exercises.
Wow.
They lay it out for you. They really do.
Wow.
They have forums. They have groups. You can ask questions. I'm telling you.
We missing out. Didn't even know.
Yeah.
Here we go. Oh, here we go. So yeah, that's what's up. So I'm definitely that's on my to-do for this week. We all walked away with homework, but that's on my to-do. All right. Well, you have a great rest of your weekend. Hopefully you will carve out 20, 30, 40 minutes, an hour to write a chapter in your ebook.
Yeah, I'm going to, this weekend is going to be, I need to crank out on the ebook and I need to, and carve out some time for this Tableau. By the time I start, I want to have a further understanding of myself so I can start with some projects in January.
Okay. Cool. All right. Well, again, thank you for being on the Saturday morning tea. Hopefully you gleaned some great tea this week. I like I said, when you started, I heard a whole shift in your voice and I knew it was coming. So that was great. So I'll talk to you next weekend or next Saturday morning at 9 a.m. if I don't talk to you sooner. All righty. Thank you.
Thank you.
Bye-bye.
Bye-bye.